A young girl of 13 years old was treated at a medical clinic for a sore on the inside of her right ankle. She had reported a prick with a piece of wood as the cause of her sore. For 2 months, she was given antibiotics and had her sore dressed every 2 to 3 days. Despite this long duration of treatment, her sore got progressively worse. For 4 days, she developed watery diarrhea 5 to 7 times per day, and on the 5th day, she developed bloody stools 6 to 7 times per day. This was accompanied by abdominal pain, and she also had a fever of 101.3 degrees. Her condition continued to deteriorate, and at this point, she was taken to a specialty clinic for fear she may have a terminal illness. At the clinic, the doctors took a careful history, did a thorough physical examination, and drew some blood to run laboratory studies. The ankle sore was about 6 centimeters in diameter, with a raised, punched-out border and a raw base. The lab results showed that she had anemia and that her kidneys were leaking protein into her urine. A sonogram showed swelling of the bowel wall, and the doctors did a biopsy of her kidneys. The symptoms she had also prompted testing for anti-nuclear antibodies, or ANA, and anti-double-stranded DNA antibodies. The diarrhea persisted, and the doctors, believing that this could be a fatal condition, hastened to make a diagnosis. Could this be dysentery? Could the young girl have a blood infection from the sore on her leg? Systemic lupus erythematosus, or SLE, is a multi-system autoimmune condition that can affect almost all the organs in the body, including the ear, the skin, the heart, the lungs, the nervous system, the kidneys, and even the bowel. In fact, it's estimated that about 50% of patients with lupus SLE develop gastrointestinal or bowel symptoms at some point during their illness. One of the most serious gastrointestinal complications of lupus is lupus mesenteric vasculitis. This is an inflammation of the blood vessels feeding the bowel. It can present with symptoms of abdominal pain, loss of appetite, diarrhea, and bloody stool. It was now becoming urgent for the doctors to make a diagnosis. Was this young patient suffering from lupus mesenteric vasculitis? To make a diagnosis of SLE, doctors often use the SLIC criteria, that is, the Systemic Lupus International Collaborating Clinics criteria, which can be used to classify a patient as having lupus. The criteria require that a physician identify 4 out of 17 criteria to make a diagnosis of lupus. Of the 4 criteria, at least 1 must be clinical, such as kidney disease or heart disease or joint disease, and another must be an abnormal lab result, such as anti-nuclear antibodies or anti-double-stranded DNA antibodies or anti-Smith antibodies. Alternatively, doctors can make a diagnosis by demonstrating kidney disease on biopsy in the presence of either a positive ANA test or a positive anti-double-stranded DNA antibody test. The kidney biopsy of this patient showed membranous glomerulopathy, which is often seen in lupus. And on top of that, the anti-nuclear antibody test and the anti-double-stranded DNA antibody test both came back positive. These findings made it clear to the doctors that this young patient was suffering from an atypical presentation of lupus. She was started on a regimen of steroids, anti-malarial drugs, and antibiotics. 1 month after the initiation of her treatment, her ulcer had decreased in size and her diarrhea had stopped. The history of this young girl clearly shows the unpredictable nature of SLE lupus. There does not exist a single set of symptoms that can give us a diagnosis of SLE lupus. Sometimes, even the least suspected symptoms may be related to lupus. Thank you for watching. Support the channel by subscribing. Until the next video, stay healthy and stay safe.